Hello, everyone. You're welcome to this question walkthrough. I'm Dr. Miranda Mawena Wuzwame, and I'll be taking you through today's question style walkthrough. Now, this question we have gives us a number of statements, and we are supposed to find out which of them are true. Now, it's a question about hand signs. Okay, so about hand signs, clubbing may be caused by complicated chronic bronchitis. Koilonychias indicates liver disease. Osler's nodes and Heberden's nodes both occur in osteoarthritis. Splinter hemorrhages are due to embolic rather than immunologic phenomena. Most joints in the hands are affected, except the distal interphalangeal joint in patients with psoriatic arthritis. So these are the statements, and one of them is true. So let's get into it and discuss each of these statements. So the first statement states that clubbing may be caused by complicated chronic bronchitis. Is this true or not? Now let's talk about nail clubbing. Now, nail clubbing is a clinical finding where you see a painless bulbous swelling of the soft tissue of the distal phalanx. You see that the distal phalanx, there is a swelling of the soft tissue, okay, and it results in the loss of the angle between the nail and the nail bed. But the exact cause really is unknown, but it is postulated that there is fibrovascular proliferation within the nail bed due to peripheral deposition of clamped megakaryocytes and platelets. So the reason why we have this bulbous swelling is because of fibrovascular proliferation within the nail bed because of the deposition of clamped megakaryocytes and platelets. So that's what's postulated as the cause of nail clubbing. Other causes have also been stated. There are various hypotheses as well. So the exact causes really is unknown. But there are a myriad of conditions where we see nail clubbing. So we have them in certain respiratory conditions, certain cardiac conditions, certain gastrointestinal condition, and other conditions. So for respiratory conditions, you may have chronic lung suppuration, so things like lung abscess, empyema, bronchiectasis, cystic fibrosis, you'll see clubbing. And then lung cancer as well, whether it's a bronchogenic carcinoma or mesothelioma, you may have clubbing. And also TB, tuberculosis, can also manifest with clubbing. Then for cardiac causes of nail clubbing, you may see it nail clubbing in infective endocarditis, cyanotic heart disease, atrial myxoma, aneurysms, and infected grafts. Then for gastrointestinal causes, you see clubbing in inflammatory bowel disease. So that's Crohn's disease, ulcerative colitis. You can also see it in liver cirrhosis, when there's malabsorption, when there's GI lymphoma. And then you may see it in thyrotoxicosis, and then it may be hereditary. So some people may be very normal, but they may inherit clubbing. Okay, so these are the causes, the common causes of nail clubbing. This list isn't exhaustive. And you realize that we do not see chronic bronchitis in the respiratory causes of nail clubbing. So let's go to our statement. Now, it says that clubbing may be caused by complicated chronic bronchitis. Now, if this statement was clubbing may be caused by chronic bronchitis, then we will say that this is a false statement. But bronchitis can be complicated by lung abscess, empyema, etc. So if you have a complicated chronic bronchitis, indeed, and if it's complicated by a lung abscess, empyema, etc., you may have nail clubbing. So this really is a true statement because of the fact that in the statement we have clubbing may be caused by complicated chronic bronchitis, but chronic bronchitis in and of itself will not necessarily give you clubbing until it's complicated by a lung abscess or empyema. Okay, so this statement is really a true statement. Okay, let's go to the next one. It says that koilonychias indicate liver disease. What is koilonychia? Now, koilonychia is this clinical finding we see where the nails are brittle, they are thin, and then they are spoon shaped or they are concave. Okay, and it's commonly caused by iron deficiency. So, chronic iron deficiency, whether it's from malnutrition, worm infestation, chronic bleeding, whether GI bleeding, GI malignancies. Okay, these all cause chronic iron deficiency and they will manifest with koilonychia or spooning of the nails. You may also have some other causes like hereditary traits from trauma, high altitudes, and exposure to petroleum products. These may cause koilonychia, but we see it more commonly when we have iron deficiency, and that's very classic. Anytime you see koilonychia, think iron deficiency, and it is up to you to investigate where this iron deficiency is coming from. Is it from malnutrition, worm infestation, GI bleeding, GI malignancies, etc.? So let's go back to the statement. Koilonychias indicate liver disease. This isn't true because really, for liver disease, one of the classic nail manifestations we see is leukonychia, which is whitening of the nails. Okay, so what you see is leukonychia rather than koilonychia. Koilonychia is indicative of iron deficiency. So this statement is false. Okay, this is false. Yes, when you have liver disease, it may result in some malnutrition, but koilonychia is not a direct indicator of liver disease. Koilonychia is more a direct indicator of iron deficiency anemia. Let's look at the next statement. It says that osler's nodes and heberden's nodes both occur in osteoarthritis. Now let's look at what osler's nodes are and what heberden's nodes are. Now, osler's nodes are these subcutaneous painful nodules that you may find on the toes and on the fingertips, and you commonly see them in infective endocarditis. So we do not see osseous nodes in osteoarthritis, we see them in infective endocarditis. And then Heberden's nodes are rather seen in osteoarthritis, okay? And it's usually because of the formation of osteophytes in the distal interphalangeal joints. So that's how you see Heberden's nodes. So Heberden's nodes is found in osteoarthritis, but osseous nodes is rather in infective endocarditis. That means that this statement will hold false. Osseous nodes and Heberden's nodes both occur in osteoarthritis. That's not true. Osseous nodes occurs in infective endocarditis, while Heberden's nodes occur in osteoarthritis. So this is a false statement. Let's look at the next one. Now, splinter hemorrhages are due to embolic rather than immunologic phenomena. Now, what are splinter hemorrhages? These are hemorrhages that occur within the nail bed, okay, along the longitudinal vasculature within the nail bed. So you see them as dark, longitudinal lines, okay, within the nail bed. Okay, so that's splinter hemorrhages. How do you get splinter hemorrhages? They can occur from trauma, from infections, for example, infective endocarditis, okay, or infected grafts where you have some septic emboli, going to the nail bed and giving you these splinter hemorrhages. You can also have it in autoimmune conditions, vasculitis, etc. You can have splinter hemorrhages. Okay, you can also have splinter hemorrhages in neoplastic conditions, some dermatologic conditions, and it may also be drug induced. So you see that splinter hemorrhages has a number of causes, including trauma, infectious causes, and autoimmune causes. So this statement will hold false because you see embolic phenomena when it comes to the infectious causes like infective endocarditis, etc. Right? And then immunologic phenomena, you see it when you have immunologic causes like the vasculitis. But it's not a true statement to say that splinter hemorrhages are due to embolic rather than immunologic phenomena. It's both. It can be due to embolic phenomena, it can be due to immunologic phenomena, it can be due to trauma, it can be drug induced, juicy. So this is a false statement. Splinter hemorrhages have various causes, including immunological causes and infectious causes, where emboli, septic emboli are, dissipated. Okay, so this is a false statement. Let's go to the next one. Now, most joints in the hands are affected except the distal interphalangeal joint in patients with psoriatic arthritis. Is this a true or false statement? Now, in psoriatic arthritis, you have both large joints and small joints being affected. And it is very common to see both proximal and distal interphalangeal joints being affected in psoriatic arthritis, a common thing. So you see in this picture, this is a picture with a patient with psoriatic arthritis. You see that the distal interphalangeal joint has been affected. So the statement is false. Okay, because it's very common to have distal interphalangeal joints being affected in patients with psoriatic arthritis. It's very common, it's very classic. So it's a false statement. Back to our question now about hand signs. Clubbing may be caused by complicated chronic bronchitis. We've seen that this is true because chronic bronchitis in and of itself has to be complicated by either lung abscess or lung empyema or other form of separation before you may see clubbing. So this is a true statement. Koilonychia indicates liver disease is a false statement. Koilonychias usually indicate iron deficiency, anemia. Osler nodes are found in infective endocarditis, while heberden nodes are found in osteoarthritis. So we can see that both occur in osteoarthritis. So this is a false statement. Splinter hemorrhages are due to embolic rather than immunological phenomena is a false statement because splinter hemorrhages have many causes, including immunologic causes, infectious causes, trauma, it can be drug induced. Now we see embolic phenomena when it comes to the infectious causes, but we also have immunological phenomena that cause splinter hemorrhages. So we cannot say that splinter hemorrhages are due to embolic phenomena rather than immunological phenomena. So this is a false statement. It actually occurs in both. Okay. Now, most joints in the hands are affected except the distal interphalangeal joint in patients with psoriatic arthritis. That is a very false statement because in psoriatic arthritis, yes, large joints are affected, small joints are affected, and it's very, very common to see involvement of the distal interphalangeal joint. So this is a very false statement. So that is it for our question cell walkthrough. I hope it was clear. Thank you very much.